all right?
Yes, we do.
Yes.
Okay. So shall we start then?
Absolutely.
I'm glad you're all here. Thank you, Gail. And we're just going to talk about skincare today, but before we talk about skincare, and please tell me if I'm either too soft or too loud as I do this, but as we talk about skincare, I think first we're just going to talk about skin for a minute. People don't necessarily realize what a dynamic organ it is, and I use the word organ on purpose because it has all the features of an organ, and it's every bit as important to us, of course, as the heart or the lungs or the brain or the liver. So we don't think of it that way. As Dr. Welliford said in, I think, her article about it when we have worries about wrinkles, we want it to stay young and dewy looking, and so if we don't have a wrinkle or a rash, sometimes we really don't think about it. Or unless we read an article in the paper that somebody was badly burned and we realize how vital our skin is in terms of our ability to really live in this world. So what does the skin have and what makes it so dynamic? It's, without getting into a whole anatomy lesson, which I wouldn't be capable of, but it has blood vessels that supply it, a network of blood vessels, little arteries, arterioles, and little blood vessels that supply it with oxygen and nutrients, just like every other part of the body. So we're going to be talking about what happens when that blood supply is interrupted, and it's every bit as dramatic, really, as when we interrupt the blood supply to the brain. We call it a stroke, and we have some tissue death there, or interrupt the blood supply to the heart, and we have some tissue death there. We call that a heart attack. And when we have the blood supply interrupted to the skin, then we get a wound or a skin ulcer, or decubitus ulcer, or pressure sore. All of those names refer to the same basic insult. So what else goes on with the skin? Well, there are several layers of skin, and they also have nerves. So we're just experiencing the world across our skin, hot, cold, wet, dry, sharp, dull. We experience the touch of a loved one. We experience pain and pleasure. So all of that happens across our skin because we have this intricate network of nerves. And then we have oil glands, and we don't like those very much, but they're important for lubrication. Then we have sweat glands, and we like them even less. There's commercial after commercial about how we can stop that awful sweating. But it's very important. It keeps us cool in the summer, and it also carries toxins and wastes away. It's the skin is actually, like the kidneys, something that will carry waste away from the body. So that said, it is really our lifelong protection against insult and injury, sun, the elements, chemicals, and most importantly, it's our first line of defense against germs. So when we have a break in the skin, we have a way for germs then to get into the body and do what germs will do. Sometimes that's very easy to take care of. We cut ourselves all the time. We wash and clean it. We put a Band-Aid on it and it heals. But with an older person, a frail person, and with risk factors we're going to discuss, a break in the skin can be a really serious or ominous thing. So.
Hello?
Hi.
Yes, Judy, go ahead.
Oh, okay. So when we have a break in the skin, we really have to be, use all caution and sometimes aggressive measures to make sure it doesn't any further. Germs get in that way. We have some germs now in hospitals. We've all been reading about it in nursing homes and facilities. And really even in the community, they are resistant to our arsenal of drugs and antibiotics. So that poses a special problem. So the best thing for us to do is to prevent skin breakdown, or when we see it occurring, to treat it very aggressively right on the front end before it gets ahead of us. I think we're still on the first slide here, and, the only reason for that list is just to, show us that we take care of our skin all our lives, and we don't think a thing about it. So when we say here, when Dana and I will be talking about clean and dry being so important, well, shower 1 to 7 days a week, depending, and we get out and we're clean, and then we dry ourselves and we make sure we're quite dry, and we apply either lotion or powder depending on our preferences or the part of our body that we're attending to. So we do this routinely all our lives. Sunscreen outdoors, more important lately, and people are really beginning to get that message, and a balanced diet, and just prevention and seeing the dermatologist. People are also beginning to use that resource more. So that's all good. So what's different about skincare for a person with Alzheimer's than skincare for anybody else of the same age or general condition? Essentially nothing. Their skin is the same as anyone else's skin of the same age or general condition. The difference is that they may become unable to observe and attend to their own needs. And so that's the lack of awareness and the possibility of not being able to take care of that. Sometimes bathing can become a problem. There may be some resistance to things that they've done all their lives and now seem difficult. So at this slide where we have a diagram of risk factors, we can see where people with Alzheimer's or dementia may come into several parts of those risk factors. As the disease progresses, we do have the decreased level of awareness. Somebody out and about recently, and she was in really earlier stages of Alzheimer's or dementia, but she went to slam the car door and just wasn't in the right position, whether that was having to do with lack of awareness or was just one of those accidents that could happen to anybody, but she certainly got a skin tear from that. So even if the person is not immobilized or bedbound, the little bit of lack of awareness of where they are in space and what a risk factor might be, that starts to become a problem. So we do have to fend for them a little bit. Immobility and incontinence, the two terrible eyes. That would be enough, those eyes, immobility and incontinence. That's enough. When they partner up, that's a real challenge for us in the healthcare community and as caregivers to make sure that skin breakdown doesn't occur. So those we're going to be talking more about. When the skin gets wet and when the person is not mobile and can't get it off of an area, then you have a real setup for skin breakdown. Nutrition is important. If there's a wound, protein becomes very important, or even in prevention. So people with low weight and surprisingly people with high weight. So whether you're on the lower end of that scale, whether you're up in the heavier end of that scale, both of those two things will be a risk factor for skin breakdown. Dehydration is definitely a risk factor. And just a word about that. I think I'm a little dehydrated myself right now, so I'm going to take a sip of water in a minute. But one sec. People as they age tend to drink less and less, and that's probably because the thirst mechanism becomes a bit duller. And maybe because they don't want to have to go to the bathroom as often if they have that awareness. But they tend to keep themselves drier and get dehydrated more easily. They don't have that buffer zone that they may have had when they were younger. Anyway, and with Alzheimer's, that may be even more so. So again, it's up to caregivers to make sure that we really offer fluids often and offer something that the person likes. If they don't like water, offer something with flavor. Juice is fine. Anything that's not carbonated or caffeinated is probably fine. Well, let me add one. Alcohol probably is not the best fluid either, but anything that's not an alcoholic beverage, a carbonated beverage, or a caffeinated beverage is considered a fluid, and we really should offer it in quantities that are not overwhelming, but, pretty frequently. I've yet to see the 85-year-old that's drinking 6 or 8 glasses of water a day, but again, that would be old. You can just see the rest: anemia, diabetes. There's another risk factor that's not on this wheel, and that is medications that a person might be on. So we're going to talk just a minute about that. And Nico, I think, can we have that slide? Let's scoot over to medications if we can. Great. Thanks. Okay. This is a list of medications that was given to us by Patricia Slatum, who's a pharmacologist and a PhD in pharmacy, working with the Department of Gerontology. So this is a great list. It's not too long, so I think we can take a look at it. But these are the medications that can cause some problems. Doxycycline or tetracycline can cause an sensitivity to sunlight. Amiodarone. It has so many side effects and so many problems that it's almost not being used anymore. There are other choices. So I'm not even going to talk about that. This is the least of its problems. Hydrochlorothiazide, a lot of people are on that. HCTZ, it's in lots of blood pressure medications, and lots of people are on it. It's a diuretic. And it does cause some sensitivity to sunlight. Dehydration. Anybody that's on Lasix or even a stronger diuretic is going to have a risk of dehydration. So we want to make sure we pay attention to their fluids. You can't take them off of that. They need it for a reason, but pay attention to their fluid intake as well, so that they're not just putting out and not taking in. Warfarin, and I think the same would be true of Plavix, and the same would be true of Coumadin probably. I don't think I can even pronounce the next one. Aspirin, ginkgo, they all increase the risk of bruising. And bruising is a skin injury beneath the surface. So where you have bruising, again, you want to pay close attention that the skin doesn't actually break over that bruise. Steroids have their uses, but wound healing is not one of them. They really can interfere with wound healing, so if there is a wound and somebody's on steroids, it needs to be brought to the attention of the doctor and make sure that they really need to be on those steroids while they're trying to heal a wound. Nutritional deficiencies, we can talk a little bit more about that, but protein is a very important thing for skin health, as are vitamins. So we'll talk a little more about nutrition if we need to later on. Okay, I think we can... Yeah, Gail.
This is Gail. I'd just like to say one thing about this topic, and it comes to me because of my work a lot with aging people and their caregivers. We often don't see, in fact, I don't think there is a line item for maybe skin status on any, assessment tools that I've ever seen. And with what Judy's just told us in a couple slides here, I think we have reason enough to think that probably when we're doing assessments for people, we should really be looking at their skin. I'm going to give you a very bold and difficult picture of something I saw yesterday at a conference. This was a policeman who had worked 26 years as an investigator, and he had gone into the home based on a complaint of a caregiver who had had his mother down in the basement of a house. And the pictures, the graphic pictures of the skin breakdown and the decubitus, which showed her spine, the bone of her spine, that slide, was really, really challenging. And this woman was a dementia client. So I want to underscore, and let Judy go ahead here, but I want to underscore the need to use skin assessment as part of an overall assessment, whether you're in a facility, in a home, or anywhere, whether you're a private caregiver. And don't let a small red bump go unnoticed, really. Mm-hmm. Okay?
Very, very good.
Any comments from the audience?
Okay, well, I think we're going to move on, and then we're going to that way we'll have plenty of time for questions and answers, too, and to hear from Dana as well. So I think moving to slide, I'm going to move to slide 4. Okay. Oh, sorry. There we are. Excuse me. So we heard in July's webinar, those of you maybe there, that falls occur most frequently in the home, not in hospital or nursing home, but just the opposite is true of skin breakdown. That occurs most frequently in the hospital, or at least begins most frequently in the hospital and or in a nursing facility, and not in the home. So why is that? Well, really, they're just two ends of the seesaw. When people become less mobile, then their risk of fall actually goes down, but their risk of skin breakdown goes up. And when they go to hospital, they're either going because they're very ill, or because they're having surgery. They may have medications and be in bed for a time. They may have fractured a hip. Any number of things. They may be going in for dehydration or infection. So they're going to be in bed, and then they may move on to a skilled nursing facility or to a nursing home even for a brief time, but they're going to be spending more time in bed. That does make them safer from falls. There may not be enough people, for instance, at night to come and get them safely to the bathroom, so they may not be falling, but they are in danger of skin breakdown. The incontinence is sometimes secondary in the hospital or in a facility, and it's secondary to the immobility. They may call for the nurse or for somebody to come and help them to the bathroom, but they may not be able to wait, and so they have what I would call a secondary incontinence. They're just as wet as the person who's truly incontinent. That's all I'll really say about that. And we will talk about wetness and the damage that can occur. I think still on this slide, let's say just a little bit about the stages. And Dana's here to...
Can I interject there just before
Sure.
you move on?
Sure.
This is Miss Dana.
Sure.
What you were saying a little bit earlier when you began this segment of your presentation, I can only speak from my personal experience, but I was actually told and I was in Richmond at the time, but I just moved up here recently to work. I was told by the nurses there, point blank, not to be upset if my father developed any type of skin irritations. It goes along with the medical condition, etc., etc. And when I say no, it doesn't. If he is kept clean, kept dry, and I constantly move him, he will not have any skin breakdown. And the nurse asked me, do you really think you're going to have that kind of time?
Now, let me have Dana speak to that. Dana Rayborg is our RN, and she's intimately involved with education in facilities and has been a director of nursing in a nursing home facility. So I think she's going to be able to speak to that nicely.
Okay.
Dana?
Hi, I'm Dana. I would have been quite appalled if I would have told that. My father, I just took care of my father, and he just passed away this past March, so I understand where you're coming from. When you're looking at facilities, I don't care where your loved one or the patient may be, whether it be at home in a facility or a hospital or long-term care, you know, as long as the patient has been turned properly, is kept clean and dry, the patient is not going to develop skin breakdown.
You're exactly right.
Exactly. And, you know, and what I'm hearing is, you know, you were being told, well, you know, they may not have the time, they may not have been well staffed enough, but that would not be your concern. You know, your concern is going to be your loved one. Mm-hmm. Was your father in a facility or?
No, he came directly from the hospital home, and I took off work, and I said I'll be back whenever I get back, and I took care of him until the day he died.
Well, I commend you very much.
Really?
Was the hospital staff the ones who told you that?
Yes, and it was.
That to me is appalling. You know,
if I
whether
said the name of the hospital, you would be surprised.
Exactly. I mean, you know, I hear a lot of that in the nursing homes and the hospitals, and I'm seeing a lot of patients coming home from the hospitals with skin breakdown and severe skin breakdown. They would have gone in with nothing, and they're coming home with what they consider stage 3 and stage 4 wounds, and that is just that is something that I think someone really needs to look at as far as putting a stop to it. I'm not sure who would do that, but that is unacceptable.
That's a bigger question, and there's a lot being written now. I've got an article just on my desk about nursing homes and staffing levels and so on and so forth. So we really, you know, I would love to talk about that now, but we probably need to focus on, thank you, Dana, so much. But we should be appalled. You know, you're exactly right, and Dana reinforces that. We should be appalled by that statement that that's normal and natural. It is not, and it's preventable, and it's our job to prevent it. So whether we can always get, you know, to 100% of our goal, you know, we can't always be 100% in every one of these, for instance, prevention factors that we're going to talk about. But we need to know what the goal is. And, of course, the goal is clean, dry, no pressure, no friction, and preventing skin breakdown, as best we can. And if we see one in a stage 1 breakdown, we need to attend to it right away so that it can easily be healed. So let's just be able to identify these stages a little bit. And as Dana said, people are coming home with stage 3 and 4. Well, I'm really appalled by that, actually. But let's identify these stages. I think we're just still really on 4, Nico, but I'm going to talk a minute about stage 1 through 4. Stage 1 is the most superficial, and that doesn't mean it's not serious, but it's a pink or reddened area, and that's what you'll see. That's all you'll see. When you remove it from pressure, when you turn the person on the other side or you remove the pressure from that, then it doesn't go away. That redness or discoloration does not go away in 5 minutes or even in 10 minutes. It remains. So now with a darker skinned person or black person, you're not going to see a pink area, but you will see a discoloration, a darkening over the skin. It's a little bit harder to observe, but very important. So that's stage 1, and that is really easily attended to if it's caught early. There's been some damage under the skin. It can happen in as little as 1 to 2 hours, but we want to attend to it very, very quickly and keep the person off of that area, some gentle massage maybe with a lubricant so there's no friction, and watch it carefully. Anything else?
The most important thing to remember when you hear the word stage 1 is the skin is completely intact. It is not at all.
Okay. All right. So if you see a broken skin and somebody say it's just stage 1, no, it's not. Skin's intact and it's just discolored and there's been a bit of damage under the surface, but it will heal if the pressure is removed and if it's kept clean and dry. So stage 2 now, that's where we do have a crack or a blistered area or some break in the skin. And it will be painful in general. It will be painful. There'll be some reddening around the edges or some mottling or discoloration, and that is stage 2. That's more serious, and it needs to be attended to quickly, because anytime you have a break in the skin, of course, you have the possibility of infection. So stage 3 is a more serious still. It's a deeper wound. Don't be fooled by the fact that wound may not be painful. The nerve endings have been damaged by the time you have stage 3 wounds. And so the person may not be complaining anymore, but the wound is deeper and more difficult to heal. Dana?
I add one more thing about stage 3. You have to look at your person as a whole when you're looking at your wounds as well. If you have a very thin person, for instance, and they have a break in the skin on their hip or any bony prominence, there is not necessarily going to be a lot of depth to your stage 3 and stage 4 wounds. I've had stage 3 and stage 4 wounds that have only been 0.3 centimeters deep. Because, as soon as the skin breaks on, say, a person who has end-stage Alzheimer's, they may not have that fatty layer of cushioning in between those layers of skin. So as soon as the skin breaks, within a couple of days, you can go directly to the bones. So
you can go very quickly from stage 1 to stage 4.
And one other thing I'd like to add, too, Judy mentioned about the beginning of feeling pain. With Alzheimer's patients and cognitively impaired patients, it may be difficult for them to express pain, to know pain, or to speak it if they're aphasic.
Exactly. So you may not know if they're having pain or not. And they may not be able to identify. I had a patient recently who said she felt bad, and we said, do you have pain? She said yes, but she really couldn't tell us where it was. Her brain really no longer identified the exact site of the pain, so it was very difficult to know what was happening there. Okay, so those are the stages. Stage 4 is a very difficult wound to heal. It can take months, even a year to heal, and they're almost always at stage 4, very susceptible to infection and sepsis. Actually, that's what happened to Christopher Reeves, and in the end, he had a stage 4 ulcer that he could not heal and eventually became infected, and that was what really he died from. Even with the best care in America, he really wasn't able to heal that wound after a period of time. So we don't want that to happen. I guess there we go. These are the three basic causes. And along with this, we're going to add another one, which Dana reminded me of, called maceration. But these are the three basic causes of the wound. They may happen separately. They may happen together. You may not know exactly what happened. But the first one is the pressure sore. The second is friction. And the third is shearing injuries. And the fourth, or the contributing factor to all of them, is something called maceration, otherwise known as wetness. Wetness is going to make the skin more susceptible to any injury. Wet skin is going to break down far faster than dry skin. So again, dry. We have to always think dry. The wetness coming from inside is great, hydration, but wetness coming from outside, think about, and remember when you were a kid and you'd stay in the pool too long, or you'd stay in the tub too long, and you'd get that white, wrinkly skin on your hands, that's maceration. That skin in an older person, or a person who's in bed much of the time, is going to break down very quickly. It's not skin that will handle much pressure. So a pressure sore, what is it? What is that? Basically, the skin and the layers of skin, be they thick or thin, are being compressed or pinched between two hard surfaces. And the hard surfaces are bony prominences and the bed or the chair. So wherever you have a bony prominence, if it's smack up against the bed or smack up against the chair, you have the danger of pressure. You have pressure, and if it stays there long enough, you can develop a pressure sore. And that is because you're cutting off the circulation to that area by squeezing it between two hard surfaces. So you get ischemia, the blood can't flow to it, and you get tissue damage. Okay. The hips are most noted for this. Also the heels and the tailbone, the sacrum. Those are the most common areas, am I right, Dana? Those are the most common areas for skin breakdown to occur because of the way we lie in bed and because of the nature of the area itself. The heels, now I don't want to say that our Creator made any mistakes, but we could have a few more blood vessels there. The heels really don't have the blood supply that the rest of the body does. Neither do the ears, but, we're not on them as much. So there really is a rule, and that is keep the heels off the bed, and we'll hear more about that later. But heels belong off the bed when somebody's on bed rest because just in a very short time, if the person cannot shift their own weight, the heels will break down. Be sure of that. When people stop walking, they're not walking anymore, or they're not walking much, the heels become what's called mushy. And a mushy heel is going to break down a lot faster than yours or mine because we're out and about. So those calluses actually serve a purpose, I think. But the mushy heel is not one we want. So keeping the heels off the bed is important. And hips, you can't keep them off the bed necessarily, but you need to rotate positions. And rule of thumb is every 2 hours. Now again, we can't necessarily always manage that, especially through the night, but that's the goal, every 2 hours, especially with somebody that's compromised in other ways. So what's our next one is friction. Okay, so friction injuries, that really occurs when the skin rubs against a resistive surface. And you wouldn't think of a sheet as being a resistive surface, but it is. It is. So if linen is pulled out from under a person, yanked out from under a person, or a person is pulled up in the bed and rubbed against the sheet, you can get an abrasion. And it might look like a very slight break in that very outer layer of skin, but if that abrasion, just like when you skin your knee or something, can lead to a terrible ulcer. So we want to avoid that. Roll the person from side to side and remove linen. It's called making an occupied bed. There's a lot of other, names, but the best thing if you're taking wet linen out from under a person would be to roll them over and roll the wet or soiled linen, including if there's a diaper involved, underneath the person, gently, gently tuck it under them, put the clean piece of linen down and whatever else you want, and roll them back to the other side and gently pull it across. That really is the only safe way, unless you have two people and you can lift the person up entirely. But even lift can cause some problems if the person is frail. So that's the rolling. The shearing injury is one where you have two forces going against each other. You have the person's skin. Remember, their skin has thinned. Their elasticity is less. The collagen layer is less. So now you have this skin, which is a little bit loose across the person, and you have them, say, sliding down in the bed, and their skin is staying against the back of the bed because maybe they've perspired, they're just sticking to the bed, and they're sliding down. So if you put a person, for instance, up in bed to eat, it's a good idea to put them down a little bit, or maybe even have them sit up in a chair to eat and then put them back in the bed when they're finished and they've digested their food sufficiently. They say 30 degrees is about the right elevation for a person's head in bed to keep them from sliding continuously down and putting pressure on either their back or their sacrum. But the shearing injury is, it can occur also when we're pulling people up in the bed, and we're pulling them against the force of being down in the bed. So using a draw sheet for moving somebody up in the bed is a very, very good idea. Have two people, and you do need two people for that. But draw sheets can be very handy for that so that you're not pulling against the person. When you pull the skin in the opposite direction from the direction the person's going, blood vessels that supply it are bent and twisted, stretched, and they can even be torn. And then, again, you're losing your blood supply to that skin, and you won't take too long before you see an ulcer there. So going to prevention. I think we're going to slide 9.
Okay.
Yes, the best thing, really, I think we're going one for that, Nico.
Backwards? Okay.
I think backwards to inspect, yeah. Our best tool, really, is to inspect the skin every day. Whether you're the caregiver or whether the person's in a facility, the opportunities for this are doing bathing, transferring, getting a person up to the commode if that's done, applying lotion. There are many opportunities just coming in. You may not be able to look at the entire person's body at one time, but you may look at their heels one time that you go in. You may be bathing them and look at their back and their sacrum and their buttocks. You may look at their elbows another time you go in. But they really need to be observed frequently and carefully. So observation is really the best tool in preventing skin breakdown, especially over pressure points and moist areas. Any sign of redness really needs to be checked and reported right away. Reducing friction, just as we said. If you can't lift the person, roll them, but never drag yank linen out. And clean and dry again. Urine and, it's not the swimming pool, and it's not the bathtub. Urine and stool are very, very irritating. So the kind of moisture that we're talking about, sometimes it's perspiration, but sometimes it's urine or stool, and those are extremely irritating to the skin. So you not only have the effect of the wetness on the skin and maceration, but you have the irritation, the chemical irritation, and the germs, involved with urine and stool. So it's really a triple whammy there. And we really need to keep people as clean and dry as often as possible. So I think we can go to the next slide. Daily bathing. One way or another, certainly if a person is bedbound or incontinent, then daily bathing is probably the best way to do that. People who are up and around don't always need a bath every day, especially if they're still able to go into the toilet on their own or with help. So hygiene and sometimes a lotion bath is okay too. We do hands and face, We do general hygiene, but they don't need a complete bath every day. It can dry the skin out. We're going to talk a little bit about lotions and creams when we finish. But basically, there are lots of good lotions and creams and powders and oils. We want to avoid things with a lot of alcohol in them, things with a lot of perfume in them, and then there are many choices there. Powder and lotion are great, but when you put them together, they form a paste. So we don't want that. They can cake up and form a paste and be pretty nasty. So the better thing would be to powder areas that want powder. It absorbs moisture nicely and helps us slip around in the bed, and lotion where we need lotion, and don't have them together. Changing positions we talked about, and the donut hole, the donut ring. We don't really use those anymore, and that's because they put undue pressure on the sacrum. Next slide. Off the bed, I think we've talked about that. Dana's talked about that as a floating heel. I love that expression. The heels should float. So you can use pillows under the calves, or you can use a rolled towel or a rolled soft blanket under back the leg, but the heels must be off the bed. Pillows to protect other areas. And I think we've gone over this slide in the rest of the talk. So maybe we can open for discussion, or shall we talk about some products? Let's open for discussion and questions, and then we can save a few minutes for products if we want. And if we run out of time, we will post the products and resources on the website that we know about, and feel free to do the same. Okay, here we go.
Any comments, questions?
Good presentation.
Has this been helpful to those of you in the audience?
Yes.
Yes, ma'am.
Okay. Diane, Denny, how did it help you?
Always knowing what can cause them and what you can do to prevent them.
So it can help, I think one of the big pieces here is education.
Really?
And I know for myself, as having a social work background, that I love hearing the clinical nurse perspective of these things, because I think we as professionals and caregivers, one of the things we're asking is for caregivers who are in the community. 80% of families are providing this care without the education and understanding. And though this is not a clinical slide presentation, I know I learned 2 new things today that I didn't know. The floating heel. I mean, I think, I understand about heels getting breakdown easily, and but I think the other parts of this, too, are really important to look at. What does this mean for our caregivers as it relates to their ability to understand, work with hospital discharge planners, work with doctors, and say, what should I expect? So I think it just brings up a lot of important issues about transitional care, and then you add the dementia and the caregiver stress, and it's really a composite that's, set for a breakdown. Skin breakdown.
Always remember, it's very important to look at what surface that the person is on, whether it be a chair or their bed at night. Like a lot of hospital beds have those basic spring mattresses. Those are very bad for the skin. There's lots of different preventative mattresses and overlays that are available out in the communities. And most definitely any patient that has Alzheimer's is going to qualify for that. You do not have to have skin breakdown to get a specialty mattress for, preventative measures. And there's lots of different prevention wheelchair cushions and cushions for chairs as well that they would qualify for as well. So that's a definite thing to look at for, prevention for any kind of pressure ulcers.
Good to know.
We can do, and one of the things that I really promoted as a visiting nurse during my visiting nurses years was preventing people from going to bed. And of course it's not entirely preventable, but if we use physical therapy appropriately and we use our other services appropriately, we can certainly put it off. If you see somebody starting to have difficulty with transfers, thinking about going to bed, sometimes that can be put off for months and even years if physical therapy or other therapies are instituted. So one of the things to prevent skin breakdown, of course, is just to keep a person up and moving as much as possible.
I think, it's really important, and this comes from sort of the global perspective, but we all need each other as an interdisciplinary team. And I think just hearing right here with nurses, social work, OT, PT, doctors, I think there is so much that we gain from each other when it comes to trying to work with our family members and community dwellers when it comes to creating a team approach to this and not being afraid to call on specialists and say, what should I really expect from this? Should I be expecting from, an assisted living nursing home, as Dana said earlier? So I think it really helps us to look at ourselves as a team.
Right. It's really impressive when you have a patient. Really, I will say, one of my favorite patients ever went into the hospital and went into the nursing home, and she was saved from a GI bleed. She had a massive GI bleed when she was in the nursing home, and they took her to the hospital in the ambulance, and they absolutely saved her life because we know how to do that. But she developed a wound in the hospital, and she ultimately died of skin breakdown and the infection that occurred afterwards. So we just have to get better at it. We're very, very good at some things, but we've got great products for treating the wounds, but we really have to get better at preventing them. So education and advocacy, again, are going to be a big part of that.
Does anybody in the audience have any suggestions for resources or the things that you can share with us that would be helpful to place on the website?
We do have some products that we were talking about, and I'm just wildly looking for them now. But one of the things that we use are moisture barriers, and a moisture barrier usually, and correct me if I'm wrong, Dana, is something that's got zinc oxide in it. Yeah, a lot of times it does, and it will just keep moisture off the skin. So we can't always keep a person dry, but we can keep the moisture away from the skin for a little while. It doesn't go for a long, long time, and we do have to clean it off,
Usually those are reapplied, several times throughout the day.
Right.
If the patient's incontinent, you would then clean the patient and reapply some more, that type of thing.
One of them that I like in particular is called Balmex, Balmex, and it just doesn't smell quite as medicinal as Desitin. So it comes in a tube, and it's always better to use a tube of something than a tub of something. When you dip in and out of a tub of something, it can develop germs in it. So tubes are better than tubs.
This is Diane. I just need to put a plug in for a wound vac. If they get to that point, we in assisted living can't necessarily work with someone who needs a wound vac that is at that extreme, but we had a resident that we transferred to Shelter in Arms, and they started with a wound vac, and I would never have thought that this woman would have survived and or been functional at all. And today she is still she came back to us, and the wound vac was able to help her to heal. She is now, this has been like a year ago, she is still doing wonderfully, pedaling herself around in her wheelchair, and without that wound vac, it wouldn't have happened, and Shelter in Arms for that matter.
Yeah, had developed the wound vac, and that is a wonderful product. It has helped a lot of patients in the community. Also, though, even with the wound vac, it's still important to look at the surfaces the patient is sleeping on, because under Medicare guidelines, it's actually, if a patient is on a wound vac for a pressure ulcer, they have to be on what they consider an air mattress or something equivalent or better than that in order for them to work together, and it actually helps them heal quicker if they're on, the appropriate surface with the wound vac. Patients heal up very rapidly, and you're right, it's a great product.
Wonderful. Well, this is a way low tech from that, but Dr. Welliford's mother is a nurse and a caregiver for her grandmother. I hope she won't mind my saying that. But she has come across something called anti-monkey butt cream. So I'm not sure how they arrived at that name, but it is anti-monkey butt cream, and we will post it on the website. We will. But people are getting very good results. People up and out about in the community. It was developed, I think, by either horseback riders or motorcyclists. But either way, they were spending a lot of time in the saddle. Right, and I guess they were warm and wearing lots of clothing, and so they found that they needed something, and that's who developed that. So we're going to post that one too. Anybody have any other products that they just love and want to share?
I have a question. Someone on the line is in an assisted living facility.
Yes, ma'am.
I have been asked recently, and I'm sorry I can't talk right today. I have been asked recently by 3 different assisted living facilities to come out and just kind of, look at the beds and the clientele with the nurse in the facility to see, would any of the residents in that facility be a candidate for a preventative type of mattress, just to help prevent in the future of any kind of skin breakdown, things like that. Have you all ever thought about maybe looking at, getting some preventative mattresses for some of your residents?
Sometimes that is, we also have our own therapy department, so sometimes that is recommended by our therapist, that they have something if we know that they're either bed-bound or are in either bed or chair a lot, then sometimes our therapist will recommend a preventative mattress of some sort.
I mean, under Medicare and Medicaid guidelines, if the patient is bedbound, they instantly qualify for any kind of prevention. And if they have limited mobility and have like incontinence or impaired sensory, like your Alzheimer's and things like that, even if they're ambulatory but they're limited, they qualify as well.
Okay.
Yeah, even if they're in assisted livings or anywhere they may be, they qualify. And Medicare covers that for them.
Okay.
Just a product for them to keep.
If they become bedbound.
If they're bedbound, they instantly
that's
qualify.
Interesting. I didn't know that. Now this is a question that I have, and I've had it for a long time, and maybe not even be relevant anymore. Foam, egg-crate foam. I've heard different things about it. There are some people that still swear by it. Usually nurses my age, but there are other people that say no, it's hot, it breeds germs, it's no good at all.
You have to have a waterproof covering on it if you're going to use it for it to be an effective type of tool.
Okay. So with a waterproof covering.
Yeah, because you're right.
A waterproof covering on what?
On foam, egg crate. Remember egg crate? And we don't use them so much anymore, but there are people that still really like them, and they're using them in their homes a lot. And people ask me, well, should I get an egg crate, and where should I get it, and so on. And I really haven't known just what to say about that. But what Dana's saying is that if it's got a waterproof cover on it, that it's okay to use. But without that, the foam really can absorb moisture, and it can grow germs right in it.
Oh, yeah.
And, yeah. Anything else? Want to wrap up?
Well, I think this has really been a very interesting topic, and I hope those of you in the audience have enjoyed it and have learned from it as we have as well. It will be posted on the website for your future use, and on behalf of Dana, Judy, myself, Dr. Welliford, and Nico, thank you for being an extraordinary technician.
Thank you. I would just like to add one more thing, that we're going to post the recording on the same newsletter, and we're going to send an email message once we have everything posted, including the slides. And please feel free to direct other colleagues or friends, other caregivers to the site, and let them know that this information is available, and just from the click of a button they can run the whole seminar, and they can contribute in our forum as well. which is open to everyone, and it's free to all. So please, just also let us know how and what else you would be interested to listen and learn, and we will make sure that we can add more webinar topics and newsletter topics as well.
And Mika, were we going to have a place where we could post resources for people, various pamphlets and guides?
Absolutely. So the newsletter itself is not going to be a static one, but we will start, continue adding resources to it. So rather than, generating more pages, we will keep everything on that page, including the recording and including the resources that we will be adding to it. So that will be pretty much the holding area where we will continue to post to this new newsletter. So it'll be a work in progress. So we'll not just archive it and then leave it away. So anyone else that may have a resource and may want to share anything from an experience to a product or a solution that might have worked for them, please feel free to email us and let us know, and we will post it for you.
Hey, Miko.
Yes?
This is Dana. I'm with Hillrom, as you know, and we're a national company. I have a lot of resources that I can get that you can give to caregivers, lots of brochures and pamphlets that are very basic, maybe have cartoon caricatures.
Fabulous.
Very helpful.
They go through prevention and treatment of your basic wounds, decubitus ulcers, and shows how they start, etc. I'm able to get those for patients or caregivers who may be interested in that as well.
Fantastic, and we will be posting everything accordingly. So once Dana will be sharing this with us, then we will direct people as to where to find them and how to get them.